Thank you, Stan. Thanks so much. So I was tasked with challenges in neurocognition. So that's what I'm going to talk about. I'm going to tell you about challenges with diagnosis, but give you a mnemonic, the rule of three. And the problem areas are probably the preclinical or asymptomatic phase, and then ruling out other causes or confounding factors. I'll talk about pathogenesis, which we're still trying to figure out, but we have some idea of what's going on. Then epidemiology, it's always interesting to try to figure out how much of hand is out there in the world, but we have some studies to look at. And then a problem area or a challenge is that although antiretroviral therapy improves neurocognition, there's still residual impairment in some. And I'll go over that with several studies. And then I'll talk briefly about the consequences of hand, which are a challenge for all clinicians, and that the preclinical or asymptomatic stage does progress in some, another challenging area, because it's not always addressed with ART. And then what we should do about treatment. Earlier intervention with ART and acute infection, and then an intensification trial, just we're about halfway through. So an overview is that HIV enters the brain within days and establishes an infection that's throughout disease. And interestingly enough, neurons aren't directly infected. So it's a secondary bystander phenomenon. In some cases, it causes a unique neurological disorder, HIV-associated neurocognitive disorders, hand. What is hand? This is hand. And this is the preclinical asymptomatic mild form, where you have neurocognitive impairment but no functional change, no problems at work. Here's the mild, more severe disorder with both cognitive impairment and functional impairment. And then the dementia that we used to see in the old days that us white hairs were used to and saw before, say, 96 or so, was severe cognitive and functional impairment. So the mnemonic I want to give you is, and how to diagnose hand is, there are three criteria that consist of neurocognitive impairment. You have to have that. And then you have to have functional impairment, plus or minus. And then you have to rule out these other conditions. And that's the challenge. This is the challenge, and clinically, practically, when you're doing the diagnosis. So here's just the neurocognitive aspects that I went over before: preclinical or asymptomatic, mild, and dementia. And then the functional impairment that goes together with the neurocognitive impairment. You can have normal functioning, and then you're in the ANI or preclinical category. Mild functional impairment, and you're in MND or mild neurocognitive disorder. And then marked functional impairment with marked neurocognitive impairment gives you HIV-associated dementia, providing that you only have incident or contributing factors and not completely confounding factors, which would be psychotic depression, very severe substance abuse, other CNS diseases such as stroke, those kinds of issues. So, and that's always the key. When you have confounding factors, you really can't make a clear diagnosis. So that's a challenge in neurocognitive issues in hand. So how do we diagnose hand? We use a neuropsychological battery, and it assesses different parts of the brain. And I'm going to go through one really quickly and just talk to you broadly about the areas of functioning we assess. A typical clinical trial battery that we used in the AIDS clinical trials group, that I'm going to talk about several studies from there that we've done, assesses language or premorbid skills, which are kind of global or across the whole brain. And then fine motor skills, which are in the motor area here. And on one side, it's dominant. And then on the other side, here, for the non-dominant, executive functioning, which is generally thought to be in the frontal lobes, attention and working memory, which is fairly well distributed, verbal learning and memory, which are hippocampus and temporal lobes generally, speed of information processing, usually deep white matter structures. And you put that all together into 7 domains that we just discussed and add the ADLs, and you can get your diagnosis. And then what causes HAM? I'm going to go through that fairly briefly. So if you look here, these red dots are the virus. And this is where the virus has a preference for deep white matter structures. And when somebody has full-blown HIV dementia, you'll see a lot of fluffy white matter changes on MRI here. But there's also virus in the frontal lobes and other places. We're going to drill down here and kind of use sort of a zoom in to what happens at the cellular level. And this is just a picture of how the virus traffics in through this blood vessel and then crosses the blood-brain barrier and infects the parenchyma of the brain. And here's another look at that sort of. So again, let me orient you. On both sides here, we have parenchyma, so brain itself. This is a vessel running through the brain. Monocytes and T cells trafficking through. There's perivascular macrophages that we think are trafficking in microglia cells. And this is the virus in blood in red. So throughout the talk, when I have red dots, red markers, that's blood, virus in the blood. And then when I have blue, that's virus in CSF or cerebrospinal fluid. So virus traffics and crosses the blood-brain barrier in these cells and then sets up a local infection. And that's denoted by the blue cells here. So the cells here are microglial and macrophages, perivascular macrophages. And then the bystander action happens with an inflammatory process. And that's what we think ultimately causes HAM. This inflammatory response to latent, low-level chronic infection within the brain. So in work we've done at UNC with Ron Swanstrom's lab, we've looked at virus in the central nervous system through cerebrospinal fluid and compared it to plasma, or the systemic compartment. And what we found is that if the virus is genetically different in the blood compared to what we get from CSF, that often indicates that there's an ongoing productive infection within the brain, and those people end up with dementia or neurocognitive impairment. So that's one of the aspects of the pathogenesis of HIV as well, that there's a productive, ongoing, genetically different viral infection within the brain versus the systemic compartment. And here's just an illustration of that. These are 4 subjects, all with HIV-associated dementia. And you can see the red dots are blood and the blue are CSF. And you can see that these are genetic trees, and there's distance here represented by the lines. And dots closer together are genetically similar, and dots farther apart are genetically distinct or different or diverse. And you can see in these subjects that there's a unique or diverse virus in the CSF compared to the blood. And this is a much fancier way of looking at this. Here we have each one of these is sequences, and it's labeled with a number. But you can see in the compartmentalized subject who has HIV-associated dementia, it's very diverse and different from the blood compartment, whereas this person has equilibrated virus, and it's genetically the same between the compartments. So on to prevalence and incidence. How much hand is there? Well, in ACTG, we've done a couple of trials that I'm going to tell you about, both US first, before antiretroviral therapy, and then I'll talk about international before antiretroviral therapy, and then I'll go on to what happens when we treat people. So these are the sites in the US, and this is a study that really looked at tenofovir versus Maravroc, and it was completed a little while ago. And we got a good look at what happens in naive people. And what we found was that there is, while 55% are normal and we saw very little dementia, there is a fair amount of MND in the preclinical phase. What about international sites where we know that the virus is different? We have different subtypes. And this is just a sort of color map of representing different subtypes across the world. And we looked at neurocognitive impairment in these settings with the sister study to 5175, which was a sub-study or allied with HPTN 052, which Stan and Tom talked about yesterday quite a bit. These are called the International Neurological Study and the Normative Study. And the first one had 860 subjects. And then we went back and collected normative data to be able to compare our results, and 2,400 subjects in these settings in sub-Saharan Africa, India, Thailand, Brazil, and Peru. And what we found was very similar to the US findings before ART, about 55% normal, 25% with mild, and 17% with moderate, and 3% with the severe findings. So about 45% have some impairment prior to ART. And what about on ART? Well, we see improved cognition, but there's residual impairment in some, even when they're virally suppressed. And let me go through that. So this is back to the first study I showed you. And when these naives go on treatment, you get a much better response in those that have mild and marked impairment, and they improve more than those that have the mild impairment. And then another study we did quite a long time ago was a sort of a meta study of 1,160 patients that all were receiving antiretroviral therapy. And similar findings there. We found mild to moderate impairment in 26% who were on ART. So our largest US neurocognitive RCTs, randomized clinical trials, demonstrate that neurocognition improves ART, but there's still residual impairment. And what about internationally? Well, we look at what happened over time in 5199 and found that there is residual impairment. And while people increased in becoming into the normal range, and mild impairment and moderate impairment decreased, there was still residual impairment, just like we see in the US. So there's something going on that we're not really addressing well, whether that's blood-brain barrier, lack of CNS penetration of antiretroviral therapy, we really don't know yet, but we need some way to, it's a challenge for us in the field to address.
Before you change the slide, could you comment on why you think the severes didn't change even a little?
Well, they're so, they did, it's just that there were only 3%, and while you just can't see that they went to zero, it's, yeah. I mean, it's a good point. Thanks. Yeah. So what about hand in the heart era? Well, as we just talked about, it's prevalent in milder forms, some residual impairment, even though art improves. But if you don't look, you don't see, and it's not really addressed in many settings. Why care about hand? Well, there are a lot of impacts. Decreased adherence to medication, impaired driving, difficulty with your daily living, less employment, and shorter survival times. So there is a cost. And what about this preclinical or asymptomatic category? That's been a challenge. It's harder to diagnose. We don't really know what it really means. There's less, if you don't have functional impairment, there's less worry about that in some respects. But we think it's a problem, and a charter study has shown that there's a 2 to 5 times increased risk to develop symptomatic hand versus staying normal, as shown here in this survival plot. And the upper blue line is where these people who were normal did not progress here onto more neurocognitive impairment, but those with the ANI or preclinical impairment went on to develop mild neurocognitive disorder at significantly more than those who were normal. So it's not a throwaway category. It does mean something, and we need to figure out how to treat it before it becomes impactful on your daily living. So what have I told you? I'll tell you again. There's residual impairment despite art. Mild hand is still prevalent. I will say that the brain is being left behind in the cure. There's just not a good way to access brain. You're not going to do brain biopsies to look at reservoir and compartment. We know there's latent virus there, but people are looking at easier targets like lymph nodes, and so we'll see what happens. So what do we do? Possibly earlier treatment to suppress HIV in the CNS, and another route is intensification with more antiretroviral therapy using different mechanisms to try to address it. So newer drugs with different mechanisms of action that cross the blood-brain barrier better than the older drugs. So let me talk about that a little bit. These are, by and large, all unpublished studies. Some of them have been presented. Some are large, but most of them are smaller. This THINK study at UNC was a collaboration between Duke, UNC, UCSF, and Yale, and Serena Smutic at Yale. And it looked at naive and experienced, but here I'm going to focus on naive, and there were 30 with follow-up out to 48 weeks here. I'm just going to talk about 24 weeks. We did a neurocognitive assessment at baseline in 24, lumbar puncture for CSF collection at baseline in 2 weeks, and we looked at change from follow-up. And the results were really interesting. What happened was, if you reduced CSF at 2 weeks, it led to improved neurocognition 6 months later. So it predicted improved thinking, as this graph shows. So neurocognitive performance here, bad down here, good up here. So as your change in CSF, and this is less change and this is more change for the good. So improved neurocognitive performance over time with reduced viral load. And then we looked at decay rate. So how fast you drop the virus, how fast you were able to suppress virus in the CNS compartment led to improved neurocognition 6 months later. And the faster you improved your virus, the better your neurocognitive performance was. So this just reiterates that decreased CSF viral load, increased decay rate, improved neurocognitive function at 6 months. So Another study we did, I'm going to talk about two studies in early intervention, one very small, Cindy Gay at UNC led, and I'm going to talk about antiretroviral therapy in acute infection, and perhaps this will decrease the CNS reservoir size and dampen the immune response. That's the thought, the logic behind early intervention to improve CNS functioning. Cindy's study that I was a part of was a UNC Duke collaboration, and we put people on antiretroviral therapy within 30 days. This is unpublished, but it's been presented at CROI. And we had follow-up at 48 weeks and 12. So these were very intensively studied individuals who had big blood draws and all kinds of workup. But one of the things we did was to look at neurocognition, and what we found was of those who remained impaired at 48 weeks, 2 out of 3 did not suppress on antiretroviral therapy, so they still had virus. Here are 2 graphs with very similar findings to the ones before, and better performance with lower HIV RNA early on and at baseline, and then the change out to 48 weeks, worse performance with higher HIV RNA. So higher viral load, bad for the brain. And again, the faster you suppress the virus, the better you do. Same thing as I told you about in the other study that was with the naives. So better neurocognition with faster suppression, and worse performance in those that were very slow in suppressing. Then the last thing I have for you is or near the last, is a big study we did in Lima with Ann Durr, and she has a cohort there called SABIES, which I think roughly translates to, my Spanish is terrible, but roughly translates to do you know? And it's in an MSM and transgender cohort that started some time ago. And it's a large cohort that's been screened, and they're serotyped into acute or recent infection, seronegative but HIV RNA positive, so within days to weeks. And then recent is within past 3 months. And they either were randomized to immediate ART or deferred ART. So this study will never be done again because of START. This was started before we knew about START, but it'll never be done again. So and these people are in continued follow-up. So this is the diagram. Over 3,000 individuals were screened, MSMs. The negatives were enrolled in the study. Some didn't return. Some were positive. They weren't enrolled in the study or put on treatment. And then of the negatives, 2,000 were retested every month. And then those who became positive were enrolled and randomized to treatment. 71 in the acute infection and 144 in the recent infection, and then randomized to immediate deferred in both arms there. So very interesting study, very interesting findings. We need to see what happens here, but this is change in overall neurocognitive functioning from baseline. That's why this is 0. And they do improve. They're very well matched on demographics, as you might imagine. And it becomes significant out here. So it's not hugely significant, but there is a significant difference in change in neurocognitive functioning at 48 weeks if you're immediately randomized to ART versus not. Just like what the START study shows for the systemic compartment. This shows it for the brain. So it's thought, perhaps in this unique cohort, that initial ART may protect the CNS. There was greater improvement in neurocognitive performance over time. And the The last thing I'm going to talk to you about is a study we're midway through, and its intensification with art. It's another ACTG, or AIDS clinical trial study in the US that's expanding internationally. And it looks at, as I said, novel mechanisms for attacking the virus in the brain. Both of these drugs get into the central nervous system well. They get across the blood-brain barrier that everybody talks about. They aren't kicked back out like most of the protease inhibitors are just immediately rejected from the brain. But Maraviroc is an R5 blocker and dolutegravir is an integrase inhibitor. So two sort of novel mechanisms. And the question is, will intensification improve neurocognition in those that have this residual neurocognitive impairment? That group that's on ART, virally suppressed, but still has cognitive impairment. It's a super challenge to us to figure out how to treat. So this is the group we're looking for, and they're randomized to either no intensification and they stay on background ART with double placebo for Maraviroc and placebo for dolutegravir. And then arm B is active dolutegravir and placebo for Maraviroc. And then arm C is active Maraviroc and active dolutegravir. It's in 30 sites in the US. We're halfway enrolled. We're expanding internationally to Durban, Johannesburg, Cape Town, Rio, Porto Alegre, and Lima. And that's because that's where the drugs are approved. We wanted to expand to Malawi and Zimbabwe and some of the other, like Thailand. I think Thailand is approved, so we're just adding them too. So we'll see. We're just a little over halfway with 100 enrolled. It's a difficult study to do because you have to do the hand diagnosis at screening and then randomize them after you get the cognitive results back. So there's no small amount of effort in doing the study. So here are the challenges that I talked about. First of all, we'd love to prevent getting HIV into the brain, but it gets there early and stays. Diagnosis is a bit of a challenge, and if you're severely confounded in this rule of 3 that I told you about, it's very hard to make the diagnosis. Then hand develops in some, usually in those with compartmentalized virus. We know that the challenge for us globally is that 45% have some mild neurocognitive before treatment, and then 20% still have residual impairment on ART. And while ART improves HIV-associated neurocognitive disorder or hand, by reducing HIV in the CSF, it leaves some with residual impairment. And ART initiation early in the disease may protect the brain from the studies I showed you. And then an intensification study is under the way. But we have a real challenge here in trying to figure out how to address hand and behind the blood-brain barrier, and to keep people, as we're living longer, productive. And you don't want to live longer with the virus that then takes your functioning away because your brain isn't working as it should. So it's a real challenge. And with that, I'm 1 minute ahead.
Thank you, Kevin. Lejean has got the first question.
Yes, thank you. What about the brain of elite control people?
Sorry?
The brain for elite control.
Oh, so that's a very interesting question. And I did have a slide in here that says we're not really doing a good job of looking at these subsets of individuals. But by and large, elite controllers do well both in the systemic compartment and neurocognitively. We don't have good data though, and we haven't really looked intensively at the elite controllers. But what we do know from few case reports that I've seen at UNC, that other people have talked to me about, is they're doing well.
That was Ray-Jean Thomas asking a question, and please tell us who you are, because some people are coming today for the first day, so they don't know everybody.
Hi, good morning. Damani Piggott from Johns Hopkins University.
Hi.
I just wanted to get your perspective on differential ART effects in the context of hand and CNS, where we stand.
So we know some, so there are a couple of factors there. Differential ART effects in terms of hand. And one is CNS penetration, and another that comes to mind is CNS neurotoxicity. So we know efavirenz is neurotoxic. The old D drugs were neurotoxic. AZT, although it is the only antiretroviral treatment for dementia that the FDA has approved, and that was done in '87, probably. It's still an issue, and if you have somebody that comes in that has neurocognitive problems, you don't want to put them on efavirenz or any of the drugs that have this side effect profile. With CNS penetration, that's a little more controversial. Studies are equivocal. Some studies have shown that it's important, and some studies have shown that it's not. In one of the larger studies done in the alert cohort, thousands of subjects, they found that it actually took more than on that CNS penetration effectiveness scale, you had to have a 7 or more, which generally meant you were on 4 drugs. So, and then other studies have just not found any difference whatsoever between a CNS penetrating regimen versus one that's not. So, still controversial.
Thanks,
Professor
Kevin.
Landis.
Yep, Professor Landis, University of the West Indies. When you started talking about inflammation, my ears perked up because that's my field. So I've got a 2-part question. Is there any interaction with diabetes? Because diabetes and hypoglycemia can cause impairments in the blood-brain barrier. The second part to my question is, have you attempted to try to suppress inflammation in sort of sophisticated ways? And what I'm thinking about in particular is agonists of the NRF2 pathway, because not only will that suppress inflammation, but actually it will also strengthen the integrity of the blood-brain barrier, so things like sulforaphane and stuff like that.
Okay, you just walked out of my world into somebody else's world, not mine. I don't do inflammatory markers or really have I know that inflammation is implicated and inflammatory markers are implicated. I also know that anything that impacts the blood-brain barrier and makes it more permeable, so if you're a diabetic, if you've had a prior insult to your brain, even trauma or stroke, and your blood-brain barrier is more permeable, you're more at risk for more virus getting in and synergistic effects with the pre-existing CNS disease and HIV dementia.
Interesting. But we can maybe discuss further, but there might be combinations of ART with anti-inflammatory treatments that might be useful.
People are thinking about that and have been thinking about that. And there's actually someone thinking about using metformin.
George Yanossi, London. I may have missed, are there people who are on treatment and the HIV is undetectable in the blood but contain a lot of in the CSF?
Are there people that have undetectable virus in the blood but have detectable virus in the CSF? Yes, about 5%. That's a term called CSF escape. So the virus escapes to the CSF, sets up a production and infection within the CNS that's resistant to whatever ART you're on, but it only happens very rarely. It's about 5%. But in those individuals, they're much more likely to have neurocognitive impairment.
Good morning, Brendan.
Morning.
Yesterday, Rajan said at the very end of his presentation, we have to do something about lobbying for, not his exact word, for reducing the cost of drugs. Thank you for a very clear presentation which brings us up to date, and I'm not saying that in any flattering sense. It does bring us up to date in this particular area. But one can feel the difference depending on where you live and which medications are available. And whereas we're going to take away the learning points from your presentation, we're not going to be able to apply them very well in the Caribbean because we don't have some of the drugs that you mentioned. But we'll wait, and our authorities have a challenge all the time about which drugs to bring into our formulary, and therefore which will be effective in the overall benefit to our patients.
Well, I agree, and I've worked in resource-limited settings for quite a long time, and I guess what I can tell you is that if you can suppress virus, you're making a huge impact. So the people that come to us with dementia now are not on antiretroviral therapy, and they're very latent disease with CD4 counts 50, very low. So if they're on any regimen that suppresses their virus in the systemic compartment, it's most likely that they're going to be suppressed in the CSF. Only 5% or so are going to have the CSF escape that George just asked about. So regardless of regimen, as long as you're suppressing virus, that's a good thing. I think if somebody complains of neurocognitive problems, as the gentleman from Hopkins alluded to, efavirenz is something to avoid if you can. If it's the only thing in your national regimen, AAA, which is still predominant in a lot of places, then that's what you have to use.
Mm-hmm. I think that your presentation does reinforce the value of early treatment.
Yes.
And all of our countries struggle over this. I heard a doctor from Nevis say that they are at under 500, which means that I know you want to move towards treat all, and I think that that's the message, but that has economic implications, doesn't it?
It has huge economic implications, and it's a reach goal even in our resource-rich settings in the U.S. It's it's really hard to identify everybody, as was talked about by Stan and Tom, and then get beyond that, get those people on treatment and staying on treatment. So,
Well, we'll give Kim the last word here, but I just, vis-a-vis the cost, it's very important to look at the decision analysis modeling literature, the econometrics literature, because early treatment saves money. And that's what the Minister of Health, and especially the Minister of Finance, needs to see. So we do have that ammunition, because when you think about it, keeping people at work, preventing hospitalization, disability. Can you imagine what an end-stage neurodementia case costs society? So as expensive as it sounds like it is, early treatment is a net cost savings. And if we can get that message into our ministries, it may be. Now, the problem is it costs money on the health ministry side, but it may save money on the other sides of the equation. You may not see it in the health system for another 10 years,
right,
what you've saved. But that's where the decision analysis models can be very helpful. Kim.
Thank you. So thanks for your presentation, Kevin. You're always very clear. But you mentioned repeatedly that hand is a difficult diagnosis. So are there any user-friendly checklists that are specific for hand? Or
yes.
Is it more
so that is a diagnostic challenge that I should have spent more time on, because most of the checklists, the mini mental status, the MOCA, the HIV dementia scale, the international HIV dementia scale that I've done a lot of work with, they're either not sensitive or not specific or both. So it's there's the Simone questions, which are just 3 questions that they're very easy to utilize. It may be a first a way to lessen the whole burden of referring for formal neurocognitive testing. But I'm happy to train people. I train people to do these batteries all over the world, and happy to train people here in the Caribbean.
All right, thank you.
All right, we'll try to keep you here in Barbados another week, Kevin. Thank you for that offer. Thank you very much.